Hi everyone, it is me, Christina Gerges, and welcome to our journal club for tonight. We are here in Psychiatry Network, and I am just waiting for Dr. Thant to join us. She's going to be presenting an article on conversion disorder. So looks like she's here on camera. Hope everybody's doing well. I see that we do have a couple people viewing already.
Hi.
Hi, Dr. Thant. Hi, how are you?
I'm good. How are you?
Good, good. Welcome, and thanks for
Thank
joining
you.
us. Yeah, thanks. I was just saying that you are presenting an article tonight on conversion disorder. Um,
Mm-hmm.
I just would like to read Dr. Thant's bio that she sent me. Dr. Theta Thant did both her general adult psychiatry residency and psychosomatic medicine fellowship at the University of Colorado in Aurora, Colorado. She currently works as an academic consultation liaison psychiatry attending at the University of Colorado, doing collaborative care with internal medicine, running an outpatient psychosomatic medicine clinic, and doing inpatient consults. Her areas of focus are marijuana, especially amongst patients with medical illnesses, how to practice psychiatry in states with legal recreation and medical marijuana, as well as working with patients with complex medical and psychiatric disorders. She publishes and lectures on both marijuana as well as group-based approaches to help patients cope with chronic medical illnesses. She loves that psychiatry gives her the chance to think outside the box and has been a member of Psychiatry Network since the summer, which she enjoys using as a way to learn from other group members. So again, welcome. And Dr. Thant and I actually met a month or two ago at the Psychosomatic
Mm-hmm.
Conference, so that was fun. It's always fun to meet
Yeah.
people from the group in person. So yeah,
Mm-hmm.
how are you doing tonight?
Good. Good. How are you?
Good,
Yes.
good, good.
All
I
right.
will let you take it away. Yeah.
All right. Sounds good. So I'm here to talk about the article Life Events and Escape in Conversion Disorder. It's published by a couple of different authors, Nicholson, Abik, Craig, Harris, Wojcik, David, and Kanan. And they're from a couple of different places, the UK, Switzerland, Australia. No big financial kind of concerns with this paper. This study looks like it was funded by the UK Medical Research Council, and there's a couple grants involved, but otherwise they didn't have any significant disclosures. And it's basically a case control study that's looking at testing the psychological model of conversion disorder using this life events and difficulty schedule, or the LEDS, for the motor subtype of conversion disorder, comparing these folks to both healthy and psychiatric controls, and trying to take a look at kind of specific events and how they relate to the symptoms, and specifically looking at these sort of escape events, which I'll talk a bit more later. And so the paper starts out by talking about how conversion disorder used to be known as hysteria, and now, it's often known as this functional neurological disorder, which essentially, right, accounts for neurological symptoms not thought to be due to neurological disease. There's a couple etiological explanations that they review in the introduction, mostly looking at like Freud and other psychological models, where they talk about kind of having intolerable emotions or affects from stressors that get converted into physical symptoms as a way to kind of reduce the affect, which they call primary gain, or change the individual circumstance, which they refer to as secondary gain. They found that assessments usually reveal that conversion disorders help patients escape from unpleasant conflicts, and that's kind of where their hypothesis is starting from. Other things they talk about is the concept of repression, basically of either having stressors at all or the severity of the stressors, as well as severe early trauma, which is usually sexual in these cases. The other thing they bring up in the introduction that's interesting is sort of this move away from including an identified stressor as part of the diagnostic criteria for conversion disorders. That used to be included, now no longer is. So you no longer have to know exactly or identify a specific stressor or trauma around the time that your conversion starts. The other thing the authors bring up is that there haven't really been controlled studies on the rate of life events and common forms of conversion, like the motor subtype or weakness or paralysis. While they do say there are some articles looking at less common types, like globus pharyngeus and functional dysphonia and things like that. They talk about a couple of different studies that won't go in depth, but one of the important ones that they reference later is an fMRI study that they were involved in, where they found that when patients were thinking about particular life events that could be relevant to their conversion disorder, there's different levels of activation in the brain involved in emotion and memory control compared to when they're thinking about other stressors that were of equal severity, but maybe not felt to be contributory or of etiological relevance to their conversion disorder. Other things that they kind of mentioned is that there's been meta-analyses that have shown that there's elevated rates of historical stressors and non-epileptic seizures. And they found that there was a prospective study that showed some preliminary evidence for predictive value of stressors prior to symptom onset. So there's a lot of interesting stuff floating out there. And so in terms of the methods of this paper, they kind of started out, so they recruited a group ultimately of about 43 patients with a conversion disorder. And for the timing period, they picked people who had symptom onset within the last 2 years. And the point of that was really to maximize stressor recall for the patients. And they recruited these folks from neurology, consult, psychiatry services, and neuropsych services. And they picked them usually mostly DSM-4 criteria, with the exception of the identified trigger. So they kind of were using the newer criteria in that sense. And then they had the diagnosis confirmed by chart review by experienced neurologists and or neuropsychiatrists. They also recruited a control group of 28 healthy controls. They pulled them from primary care registers in the same geographical area as the conversion disorder folks, which was Southeast London. And they kind of used random sampling to match for age and gender. And then they also had another group, which was the psychiatric control group, which was 28 patients with had major depressive disorder. And they were actually recruited from a prior study that was done in the same locations. They weren't recruited specifically for this, they just pulled the information from there. They excluded people who are non-fluent English speakers, people with current or historical neurological disorders, somatoform disorders, or major mental disorders, which they classified primarily as psychotic spectrum disorders. So that was the exclusionary criteria. The next section of the paper talks about life events assessment. And so that's a scale that actually I had not really heard much about before I read this paper. That's also called the LEDS. And the function of that is to assess stressors in the form of events or discrete episodes and difficulties lasting at least 2 weeks. And so it looks at a couple different life domains, including like health, living, employment, abuse, specifically sexual and physical, in what they refer to as a semi-structured format that lasts about 2 to 4 hours. So it's a pretty comprehensive scale. It's been validated in other studies, I guess, and they talk about high inter-rater reliability, and I can accurately detect stressors 5 years after they occur, which is pretty impressive. All the interviewers in the study underwent formal training to use the LEDs, and they really wanted to use it to look at the nature and severity and timing of stressors in the study periods that they talk about later. And so specifically for the conversion disorder group and the major depression group, the study period was primarily the year before symptom onset. For the healthy controls, they allowed up to 2 years prior to the interview date to try to basically account for the reliability of recall, minimize differences in time between the interview and life event. So they gave them kind of a bigger period is how they described it. They looked at things like event severity, and they were scored a couple different ways. One was objectively by a consensus panel, and the other was subjectively according to the interviewer's impression of the patient's kind of description of the event. And then they kind of scored them. There was a scale from 1 to 4. Severe events were ones that counted as long-term threat or severity that were scored of either 1, which they classified as marked threat or severity, or 2, which was moderate, meaning that, and also that the threat focused on the respondent. This is in comparison to the non-severe events, which had a score of 3, which was some threat, or 4, little to no threat, or included moderate threat events that did not focus on the respondent, but instead someone else around them. They also looked at underreported events, which are actually supposed to be a proxy for repression. So basically instances where the subjective levels of severity from the patient were judged lower than, or by the interviewer were judged lower than objective ratings. And then they mentioned this sort of other category called difficulties, which were also scored from 1 to 4, with 4 being kind of on the lower side and 1, 2, or 3 being on the higher side. They then talk about a novel rating that they kind of came up with for escape potential of events. And so the whole idea behind this scoring is to estimate the extent to which the impact of a stressor might be improved by being ill with these conversion disorder symptoms. And so the examples were like, would weakness that allowed you to escape from like a bully or authority figure or abusive parent, or weakness that would prevent a partner from leaving you and they would need to stay and take care of you. So that was kind of what they rated as escape events. This was also, or rather, this was on a scale of 0 to 3, where 0 equals no escape kind of potential, and 3 being a very high level of escape potential. They also talked about contextual things being important. So like if you had a partner die and that was an event, that's different because your weakness doesn't kind of improve your situation versus if a partner's trying to leave you. So they kind of mentioned that it wasn't just the event itself, but exactly what was going on in the situation.
Oh, and Dr. Thant, we just have a quick
Yeah.
question. What was the age group? Somebody missed the age group.
Oh, so the age group kind of ranged from, let's see, what, I don't think I actually said it. They said they were, this is, I think comes up in table 1. So standard deviation, so usually around in their 30s was kind of the age,
Okay.
the main age
Great.
for that. And so, where was I? And so in terms of the conversion disorder patients, they sort of were assessing, like they were taking events and trying to decide how potentially relevant were these as far as etiologic events for conversion disorder. And so they were also looking at severity of the events, closeness to onset of the conversion symptoms, and escape rating. And events that scored highly on those 3 categories were called key events. So there's a lot of vocab that they define in the study. And what they did was they compared the formulations developed by using the life events assessments compared to clinical team formulations. And what they did was if they found the key, quote unquote, key event in the clinical formulation, it was counted as previously identified versus if they identified it and it was not in the clinical formulation, which is, this is more important later. They also checked a couple other skills, mostly IQ and depression. They used the hospital anxiety and depression scale for that, and then they used the National Adult Reading Test for IQ. In terms of power, they were really trying to aim to kind of be just within a conventional level. So they were aiming for at least 40 conversion disorder patients, 40 control patients, aiming for significance level of 0.05 and 80% power, and a standard size, effect size of 0.57. Which they achieved. And in terms of their analysis, this is not an area of strength for me, but they basically looked at median and mean number of events per unit time and adjusted it to annual rates. And then they compared this between groups using the Mann-Whitney U-test and chi-squared and things like that. And then they calculated odds ratio, aiming for, of course, a 95% confidence interval. And so kind of moving on to results. So this next section, the table you want to look at is table 1, because that's subject characteristics. And so what they basically found is they initially recruited 47 conversion disorder patients. They then had to exclude 4. One was because they ended up being diagnosed with myasthenia gravis. 2 ended up with memory impairment. And 1 had a form of speech impairment that prevented them from completing the LEDs. So they ended up with 43 conversion disorder patients. You found that, if you can see from the chart, they found 28 kind of healthy controls and 28 depression. So that was where they ended up with. When you look at kind of the statistics, the 3 comparison groups didn't have significant differences in terms of gender. It was predominantly female, 79.1% for conversion disorder, 71% for healthy, and 78% for depression. They also didn't have much differences in age. Like I said, the average age between the 3 groups was 38 to 39 years old. They also found fairly similar states in terms of marital status, with most of them being married, and then social class, which they used a UK rating for that, the UK Registrar General Classification. So that's where you see this 1 through 5 rating, which they don't really go into depth explaining that. The things of note kind of in this table, other than the fact that the groups are pretty comparable, is that the depression scores were significantly higher in the conversion disorder patients compared to healthy controls. Anxiety scores were also higher, but not as much. And so you can kind of see that for the HADS depression scores, they were kind of rating an 8.3 versus 5.1 in the healthy group. They also noticed that the conversion disorder patients had significantly lower estimated IQs, but didn't differ in terms of the age at which they left education, which was interesting. So that was the other kind of big thing to take away from table 1. So moving on, and that was kind of all the things they talk about the subject characteristics portion of their paper. So moving on to the events portion of the paper. So they analyzed the events in terms of both the presence of a single event and the mean number of events per period of time, which they refer to as epochs. the idea, they weren't sure whether single stressor was likely to be relevant to onset of the conversion disorder, or whether you had to have a certain accumulation of stressors exceeding a threshold to then develop conversion disorder. In terms of nature and timing of events, they took severity, escape, and combined them into 4 key groups. So they had one group called all events, which was of any severity, then severe events, high events, and then severe high events was their rating. They also picked 3 main time periods to look at to assess basically the temporal association between the stressor and the onset of conversion. And so the ones they looked at were either whole study period, last 3 months, last month, and then for the conversion disorder patients and healthy controls, they also looked at last week and last 24 hours prior to symptom onset. The next section is the nature of events, and this is where we'll kind of look at tables 2 and 3. So if you start out by looking at table 2, so here they're talking about the number of subjects with at least one life event per epoch in patients with conversion disorder, healthy controls, and depression. So you can see they have the epoch and event type on the left, so the whole study, last 3 months and last month. They have it broken down between all events, severe, escape, and severe escape. And so looking at that, they found that generally speaking, for conversion disorder patients, there was a higher rates of all events compared to both control groups for all time periods. They also found significantly elevated rates of both severe life events and high escape events compared to both controls. And again, the high escape events are the ones that kind of allow you to change your situation. And they came up with that rating scale themselves. The other thing that you can see here is that 56% of conversion disorder patients had at least one severe event in the month prior to symptom onset. This is compared to 21% of the depression group and 18% of the healthy controls group. And so they have the odds ratios all kind of there. I won't read them all to you, but the numbers are pretty good because you can find that the odds ratios are falling within the confidence interval ranges and the p-values are pretty low. In the same time period, they found that 53% of conversion patients had at least one high escape event versus 14% in the depression group and 0% in the healthy control groups, which was pretty significant. Shifting to table 3, which is rates of life events in conversion disorder, healthy controls, and depression. They found that the total number of severe events per year in the last month. So this is where they start comparing median number of events between the 3 groups. So they found a median of 12 groups in the a median of 12 severe events in the conversion disorder group versus 0 for depression and 0 for healthy. There's some differences in the mean. They found a mean of 6.7 severe events in the conversion group per year in the last month. 3 for depression and 2.1 for healthy. The other thing they kind of noticed was high escape events per year. So again, using their novel rating score instead of the LEDs, they found a median of 12 high escape events per year for the conversion group, a median of 0 with a mean of 2.1 for depression, and a median of 0 and a mean of 0 for healthy. So again, a pretty significant finding there in terms of the high escape events for conversion versus healthy. And then when they included severe events in addition to the high escape events, this difference became even more stark. One thing that they did find that was interesting, that they found rates of underreported events, so remember that's the proxy for the repression, was pretty low for the entire study period for everyone. So they didn't find a lot regarding that. And again, the numbers are pretty good if you're looking at, oh, sorry, no, not for this one, but so that was kind of what they compared. There was a pretty big difference in the conversion disorder patients and the control groups. The next section, they talked briefly about difficulties, where they basically found that there wasn't a significant increase in the number of severe difficulties between the groups. So they found difficulties of high escape more frequent in the conversion disorder compared to healthy controls, but not compared to depression. So it didn't really separate out there in terms of the psychiatric control versus the healthy controls. The next section is the timing of events, which leads you to figure 1. So if you look at figure 1, you'll see kind of along the x-axis, they break it down to the epochs. So the whole study, last 3 months, last 1 month, last week, and last day. And then within each of those epochs, they break it down into the 3 groups of depression versus healthy versus controls. And then each one of those bars is broken down between the severity of events, basically. And then on the y-axis, they talk about the mean number of events per year. And so things to note in figure 1 is that there were generally increasing rates of events seen for all groups the closer you kind of got to symptom onset. So you can kind of see the bars getting taller. And then for the healthy controls, the equivalent was that the number of events was increased towards the end of the study period for healthy controls. The other thing that you can see is that especially there's a spike in the last week and last day for the conversion disorder patients in terms of their mean number of events prior to symptom onset. And you can see that within the breakdown of the severity of events, there's a big spike as well in the severe escape events. So if you look here, the conversion disorder rates of all events went to, let's see, 19.4 in the last last month, and then 59.1 in the last day. So there's a big spike there. And then the black portion of the bar, which is the severe escape events, also increases. And so there's an escalating proportion of their events being severe the closer they got to the sort of expression of their conversion symptoms. The next section was talking about kind of abuse and the breakdown of the report of abuse in the patients in the study. And so they talk a lot about sexual and physical abuse. And they connected to table 4, which shows the rates of abuse in conversion disorder, healthy controls, and depression. And so here what you can see is that they broke it down between the sexual abuse and physical abuse, and then broke it down between gender and then total, and then show that across all the groups, and then in the groups in comparison to each other. And so what they found was that of conversion disorder patients, 51%, which was 22 of the 43, reported some type of previous abuse. 41 or almost 42% of them reported sexual abuse in the past, and almost 24% of them reported physical abuse in the past. The authors found that the rates of sexual but not physical abuse were significantly higher in conversion disorder patients compared to the healthy controls, which I don't think is very surprising if you work with this population. And then when they broke it down with the female depression group, they found kind of intermediate rates of sexual abuse, kind of 30%, and similar rates of physical abuse, about 22, 23% compared to conversion disorder and healthy controls. But then when they pulled out the kind of male depression cases, there wasn't enough there to find comparative rates there. And so that's kind of the big takeaways from table 4 is that, you know, there's huge rates of abuse, but especially sexual abuse in that population. The next section the authors talked about was the etiological formulation or key events. And so they were looking at what they found through the study was that for almost all conversion disorder patients, you could find key events, or you could identify key events or some sort of psychological formulation for them. They said up to 91% of the conversion disorder patients, they found this. There were gender-specific themes that emerged in terms of the types of stressors. And so out of 33 females, they found that 12 reported seeing or hearing about a previous abuser as part of their stressor. 5 had some sort of marriage or partner event, and 2 of them had termination of pregnancy. So those are the big themes for the female groups. For the males, they found that 6 out of 10 reported some sort of work-related event, and 4 reported accidents where others were potentially to blame, so some sort of loss of control. So the majority of patients, about 88% of them, and this was the kind of the big thing about the structured LEDS assessment, is that 88% of the patients in the study, the key events had not been documented in the clinical notes prior to the study. And so they're sort of claiming that they found a big event in 88% of the patients by doing their assessment. And so kind of moving on to the later part of the paper, so the discussion and limitations. There's a couple take-home points. I'm going to save those for the very end. But so limitations of the study, they identify a couple different biases, which I largely agreed with when I read the paper. One was that the conversion disorder patients were recruited from specialist services. So the idea was that this may have biased the selection towards sicker patients, more refractory cases that would make this less generalizable depending on which population you're working with. Interviewers were not blinded, but the consensus panels were. And then the healthy, they had some issues kind of standardizing the times between the different groups. So the healthy controls ended up having slightly shorter times. This wasn't super significant, 1.96 years versus 2.42 years between the study period start dates and their interview dates. So they had some concern about how this could impact recall kind of their recall in the study. What they also talked about that was interesting was that could this be balanced out by sort of, in the conversion disorder group, there tends to be memory issues with the conversion disorder patients. And so memory deficits in conversion disorder could lead to a similar recall bias. And so the argument was like, maybe this wasn't a big deal. The other thing that they kind of talked about, and this was a little bit kind of a less impressive limitation, was that if by using the standardized LEDS assessment, that you could result in either underestimations of an event because a patient might be unwilling to kind of disclose it, or overestimations by sort of triggering false memories. And so, but the idea is that that could happen with sort of any detection method or assessment method, and I would agree with that, but that was another thing that the authors brought up. The other thing that was kind of interesting about the way they recruited their groups was, so they recruited the healthy controls and the conversion controls specifically for the study, but for their psychiatric controls, they kind of pulled them from a prior study. And so they were lacking some comparing data. So the IQ scores and the HAD scores, they couldn't compare because they didn't have that from the psychiatric study prior. So the depression cases had been interviewed using a different scale, the present state examination, which am not really familiar with. But they felt that that was something that could kind of correlate with DSM characterizations and criteria. But they were able to kind of match, again, geographical area, age, sex, and other socioeconomic variables, just not the scales that they actually used to rate them. In terms of the healthy controls, they found, again, that they couldn't quite match things like IQ. So the average IQ score in the healthy controls was 109.5 versus 100.3 in the conversion disorder group. And again, that bias might be more just healthier individuals wanting to take part in the study. And then they also did not have a neurological control group. And I do think that's sort of important because things that we do know is that in neurological disorders, stress and having stressors can worsen some disorders. And so they found, there's been studies talking about that in things like migraine or even non-neurological disorders like heart attack, psoriasis. But they have found that there's elevated rates of life events in stroke patients and multiple sclerosis patients, although it is at a much lower rate than conversion disorder patients. So in terms of implications, so they went and talked back to the beginning, talking about the psychological model and Freudian's theories of conversion disorder. And so what they found was that the fact that they found elevated rates of stressors in a year prior to onset of conversion supported this idea that of the psychological model of conversion disorder. But what they found also, though, through the study was that stressors were relatively common in the control groups as well. They weren't completely absent. And so what they're saying is like, well, it says that this is important, it's a factor, but it doesn't prove that it's ideologically relevant to conversion disorder. But the part that was more relevant to kind of confirming or supporting ideological relevance was the fact that there was these rapidly escalating rates of severe events found in conversion disorders closer you got to the onset of symptoms, but not as much with controls. And so that was going back to figure 1, where there was a big spike in the conversion disorder bars. And so the other thing they kind of talk about is that life events before and around the time of symptom onset are, the basis of our psychological formulations when it comes to conversion patients. But the fact is that some stressors around the time of onset of symptoms could be just chance and may not actually be impacting onset of conversion. That was something that the authors talked about. And so their takeaway there was sort of that, like, it's really important to do a very good psychological formulation for the patients instead of just patching something together and sort of assigning, I guess, false value to any stressor that happens to occur around the same time. They sort of argued that the method that they used in the study was supported by their fMRI study that they talked about earlier, where there's some events that may have equal severity, but trigger different levels of activation in the brain. And so that not all severe events are created equal is sort of their main point there. And that the only way you can really decide if an event really is relevant to the conversion disorder is by really doing a detailed examination of it and really kind of picking it apart to see if it kind of matches and is there sort of that pattern there to support it being relevant for the conversion disorder. They said also the kind of outcomes from this paper supported, because you couldn't always establish the etiological relevance of each stressor, just that the stressor was there, that they also supported downgrading the importance of stressor identification as part of diagnostic criteria for conversion disorder. But they did find that by using the structured assessment versus just a clinical assessment, they were capturing way more events. They found 4 times more relevant stressors than standard clinical interviews by their kind of review. Also, there's implications for the Freudian theory. So the whole idea of Freudians, their novel escape rating kind of looked at Freud's secondary gains, that is, a conversion disorder will allow you to escape a certain circumstance. Again, they were like, it's kind of difficult. They had more severe and chronic patients in their group for the study, but that seemed to fit better maybe with the secondary gain findings. There's also, they brought this idea of maintenance, symptom maintenance, and what does that kind of get you? So for folks who are ending on disability or kind of things like that, is there gain in having these symptoms go on without getting better? But the other interesting thing they found was that there's a significant proportion, or they report a significant proportion of conversion patients that had no escape events that they could really identify. What the other thing they kind of comment on is their repression. So this, that they talked about using underreported events. They didn't find much for that. They weren't looking at it in a very kind of nuanced way, but they didn't find much significance there. But the other thing that they found that was supported was this idea of history of sexual trauma being very important for patients with conversion symptoms. Because either that this, they had sexual trauma near the onset of symptoms, or somehow are re-triggered or reminded of the prior trauma close to symptom onset. So there was a kind of relationship there. But they felt that was a little bit difficult to pin down because there's the rates of sexual trauma in the general population was still pretty high as well. So they were like, maybe, but it's definitely quite elevated in the conversion disorder folks. And so what they found was like that level of, they said their study was in line with prior studies that had found interactions between sexual abuse, family dysfunction, and the seizure variant of conversion disorder. And I would say from my clinical experience, so right now I'm doing a half day a week in a non-epileptic seizure clinic. And this is huge. So many of them have seizure, sexual abuse, and so many of them have family dysfunction. That's very apparent when they like walk in the door with their family members. Other things to kind of comment on is like nature and chronicity of abuse could be relevant. There's other studies that have sort of shown that in motor conversion disorder, there were strong associations with incestual or chronic sexual abuse compared to like a one-time sexual assault. Some other things they talk about is potential mechanisms. So the stress diathesis models, that's a big one if you go reading about conversion disorder or non-epileptic seizures. And the idea there is that individuals all have somewhat different susceptibilities or thresholds for developing a conversion disorder. And the idea, and that sort of is maybe explains the paradox between how some people can experience a lot of stressors that seem relevant to conversion and some people don't. There's a lot of factors that go into the stress diathesis model. I mean, there's biological, so and they comment on things like the HPA axis functioning, your physiological stress responses, your psychological factors, so your personality style, coping style, illness, models that you've had in your life, as well as genetic programming and environmental factors, such as things you've experienced. They kind of comment on other studies that have shown elevated basal cortical levels, and specifically the seizure variant of conversion disorder that seem to correlate with levels of childhood abuse. So they're kind of showing that there is a lot of, the stress diathesis model might make sense for these patients. They also brought up an interesting thing about PTSD studies, where some PTSD studies have shown that there's HPA axis variation and different kinds of genes that interact with childhood abuse. And so when those get activated, it can increase your risk of developing PTSD. And there seem to be some high-risk individuals that have certain genetic variants that when they're exposed to childhood trauma, they seem to develop PTSD after what we might consider less traumatic events compared to some people who are low risk, who experience huge events and don't develop PTSD. So they're sort of saying that this could be something relevant to conversion disorder patients, as some of them are genetically predisposed to developing this compared to other people. And so kind of going to conclusions and takeaway points, big things is that there are significantly elevated rates of both severe life events and high escape events in both the conversion disorder patients, but also the control patients, but that it really broke away. The closer you got to symptom onset, there was a bigger jump for the conversion patients. There's also a much higher rate of sexual abuse in the conversion folks versus the controls. And that for a lot of the female patients, that even if the sexual abuse was more remote, they had some sort of re-triggering event near the onset of their conversion. And the other big thing was that the majority of potentially etiologic relevant events were not picked up prior to the LEDS assessment. And then the other thing that's interesting is that they found about 10% of the conversion folks, they couldn't find any severe life events to correlate with their symptoms. And so those were kind of the big takeaways from that article. It was basically that they found some stuff supporting kind of Freud and the psychological models of conversion disorder. And that maybe despite our best efforts, we might be missing relevance of stressors in our patient's story, especially depending on how they may present their stressors and trauma to us, or how the level to which we explore them. So, yeah. Were there any
thank
questions?
You. That was It looked like there was one question asking about whether we could clinically use the LEDS assessment as a tool for therapy, potentially. It just seemed like it
Oh.
would potentially be a great tool for one of our members.
Yeah, no, I think that's interesting. I think the thing that would make it the hardest is the fact that they report that it took somewhere between 2 to 4 hours to use. So I think
Okay,
it
so it's
depends
not a
what
quick screening
it's not
tool.
a
Yeah.
pick. Yeah, it's not a quick. I think if it was, that'd be great. But this sounds like it took hours to assess just
Mm,
those events, and so I think that would depend on
yeah.
your practice as to whether. I think in my setting,
Yeah.
that wouldn't work quite as well. I have one
Sure.
hour to see one of these patients, and 30
Yeah.
minutes to see a follow-up, so it's a little bit different. But I think it's interesting. In the patients I've seen in my non-epileptic seizure clinic, I've definitely kind of seen this play out where they people are like, well, we can't identify trauma, but go meet with a psychiatrist and maybe they'll find something. And for some
Mm-hmm.
of them, it's interesting because what I identify, I won't necessarily tell them at the first session, but what I identify
Mm-hmm.
is more of a upsetting pattern. There's no big traumatic event. They just sort of seem to have a
Mm-hmm.
repeated relational pattern or role in their support thing that
Mm-hmm.
seems to be the actual trigger for the conversion disorder and seems to
Mm-hmm.
be the circumstance in which if you talk about this escape rating that it might be serving for them.
Mm-hmm.
Of course, some
Yeah.
of the folks have big trauma histories, but some of them don't. It's more just like their role in their life has been a certain way.
Yeah, I think the rates, it was almost surprising to me. It was only about 50% have a trauma history. So that means
Yeah,
50% don't have a trauma history, which is a
exactly.
lot, I think. Yeah, more than
And I
we
think that's
probably thought
big.
before.
And I think
Yeah.
where I thought this
Yeah.
article would be helpful for my practice was like, I have a lot of patients who come in after being diagnosed in an epilepsy monitoring unit with NES. They come in
Mm.
and say, well, I don't have trauma. So how can I have
Hmm.
NES? Everyone's telling me that NES is
Yeah.
trauma driven. And I think
Yeah.
this paper is sort of useful to show like, well, yes and no. There's a huge percentage in this group that like did not have any trauma. And so there's something else we're not
Yeah.
catching in your,
Yeah.
in your life.
Yeah. But I do love this
So.
definition of escape events. It's a nice way of putting what that is. So yeah, that's a
Yeah, I
great
thought so
term that I'd never
too.
heard before. Yeah. So
No,
well,
yeah,
thank
I
you
think they came up.
again.
I never
Yeah.
heard it that way.
Yeah.
Yeah, thanks. Thanks for having
But yeah,
me.
thank you again. Yeah, this was great. Very detailed and thorough dissection of this article, and hopefully, I think we got a lot of views, and people can continue to watch it afterwards. I put the link to the American Psychiatric Institute, who's sponsoring the CME. You just have to go, and if you don't have an account, create an account, answer the 3 CME questions for this video or any other video that you watch, and you'll get free CME. And if you're not on our mailing list, just email me at psychiatrynetwork@gmail.com. So thanks as
All
always,
right.
and we'll see you next time. Bye.
Thanks. Bye.